Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer. Fertility expert Dr. Amy Ambartstumyan.
And you have yet another success story
Just launched by an East Bay fertility doctor.
Hi, everyone. Welcome to the Egg Whisperer Show. I'm so excited to have one of my dearest fertility doctor friends on today's show. Her name is Dr. Gayane Ambartsumyan. Hi, Gayane.
Hi, Dr. Amy. It's so good to see you.
It's awesome to see you, too. Her patients lovingly call her Dr. A. I mean, we can kind of relate. We both have really, really long last names, so it's really nice that you make it easy for people. Dr. A and I go way back. We know each other from when we were at UCLA together, so that's how long, but it feels like yesterday. And she's one of California, if not the country's top fertility doctors, working at one of the top fertility centers as well. And we're here to talk about the best strategies to achieve IVF success. Before we get into the topic of today's show, I just want to tell you a little bit about her and why she's so amazing. She completed her residency in OB/GYN and fellowship in reproductive endocrinology and fertility at UCLA. Prior to that, she received a doctorate, a PhD in stem cell biology at UCLA as well. She's board certified in both OB/GYN and in fertility, and she has been awarded or was awarded a prestigious clinical investigator grant 2 years in a row from California's Institute of Regenerative Medicine. So she's basically a badass, okay? That's what I'm trying to say here. And she's perfect for this show. So Gayane, tell us a little bit more about yourself.
Thank you so much, first of all, Amy, for having me and for that lovely introduction. So as you said, we go way back. We met each other in medical school, and those were the good times, right? Now that we look back, although we couldn't wait to finish school and start working, right? We thought we were going to do this within like a few years and conquer the world. But I feel like now, like 20 years later, we are conquering the world. So that's great.
Yeah. One embryo at a time, that's for sure. Bringing love into this world.
One pregnancy at a time. But yeah, like as Amy said, I'm a fertility specialist in California, specifically in the South Bay, Redondo Beach, with reproductive partners. I'm in a group practice, a little bit different from Dr. Amy. There's 7 other physicians in my practice, and we just help women have choices and have babies, and one baby and one woman at a time, like I said. And I love what I do.
Yeah, I mean, we go into this because we're very positive people. But tell me a little bit about, I love hearing from other fertility doctors why you went into medicine and why fertility medicine specifically.
Yeah, so it's a little bit of a long story because I wasn't one of those people who went, from like day one said, I'm going to be a fertility doctor, right? So I think a lot of what's happened through my life and career has kind of molded that, but in a really good way because I love what I do right now and I can't have it in any other way. So I grew up actually wanting to be a musician. I thought I would be a musician. Or I thought maybe I would be a surgeon because it just kind of sounded cool to operate, right? And then my family moved to the US and those circumstances changed the fact that I could no longer really pursue music. So I went to college and science really inspired me. But what inspired me about medicine is that you could use science and apply to actually help people and heal people and whatever specialty you go into to just, help people in that specific specialty. And women's health was actually a pretty easy choice because I just love working with women, helping in any aspects of their care. And initially, actually in residency, you may or may not remember this, but I wasn't really interested in fertility. I thought I would go into oncology and help women from that perspective. But then when I did my fertility rotation, finally, it was almost like a light bulb, like something clicked and I was like, this is what I want to do. So here I am many years later.
So we want to learn from you and all your experience. And I think it would really help our listeners if we could hear as you talk through how you approach IVF care and what you do to help your patients achieve success. So I want to throw out some scenarios for you to guide us through. How do you decide which protocol you should put a patient on? And I'll give you the patient example. A 25-year-old egg freezing patient with an AMH of 4.0. What is your protocol of choice and why?
So that's a good question. First of all, let me address the very first one. How do you approach fertility care? And it's really, it's like we said earlier, each patient, each retrieval, and each baby, individual person at a time. So I really kind of look at the big picture. First of all, I make sure they're prepared to embark on this journey. I make sure we have looked at all their blood work, all their evaluation, but at the same time, I just also want to make sure they're ready emotionally, physically, spiritually. So we talk about nutrition, we talk about stress reduction, we talk about yoga, relaxation, acupuncture, whatever is going to help that particular woman to go through the journey, because it's not easy and it has a lot of steps, and we tell them we're here to hold your hand, but it's still they're the ones who have to do a lot of the work. So going back to the second part of the question, someone who is young, where we know they're going to have hopefully good quality eggs and good number of eggs and have good AMH, which means they have good number of eggs in their reserve, I generally go gentle. But I tell them it's a fine balance, right? Because if I go too gentle, then we're not maximizing our ability to retrieve eggs, especially if we're freezing eggs. But at the same time, if we go too harsh and use too many medications, too high doses of medications, then they're going to hyperstimulate, and it's just not going to be a pleasant experience, which may impact their egg quality. So I generally go, medium dose, like 150, a total of maximum about 225 units of gonadotropins, and monitor them closely. And if they need their dose needs to be adjusted, then we adjust their dose. And generally for those patients, I do something called a loop run trigger. And the loop run trigger, what it does is it decreases the risk of ovarian hyperstimulation syndrome, especially after the trigger and after the egg retrieval. So they have an easier and quicker and better recovery.
Awesome. So it sounds like you do a lot of hand-holding, guiding the patient, and making sure she stays safe from start to finish. Cool. So let's change. So let's change the scenario a little bit. Let's say you have a 37-year-old with an AMH of 0.6. What would your protocol of choice be in that type of situation?
So those are, those of course end up being a little bit more of the challenging cases, right? So there's so many questions that arise. But why, first of all, why is my AMH so low? Why is my AMH 0.7 versus 1.5? Have I done something wrong? Is it something that I did? Did I drink too much coffee, too much alcohol? First of all, none of it is a woman's fault, obviously. Well, it's our fault for being women because that's part of our biology, right? But that's just something, it's information that we use, but a lot of it is also managing expectations. So someone who has lower egg reserve potentially with that AMH, I know I need to manage their expectations and tell them, look, you're not going to get 20 eggs like your friend. You're probably going to get maybe 6 eggs, 8 eggs. So that's how I initially approach them, because a lot of this is really managing expectations so the patients aren't disappointed. But at the same time, actually, a lot of what I do with her category of patients actually do something we call in our practice mild stimulation IVF. So it's in a way it's counterintuitive, and it sounds counterintuitive to patients too. And they say, what do you mean? You're going to give me less medications? Yes, because we already know we have finite number of eggs this month. We're not going to make 20 eggs. We're not even going to make maybe 10, 12 eggs. So why bother giving you all these high doses of medications that are probably going to just, put just too much, pressure on your body, too much of these injections, and we just go gentle. So I usually do a combination of Clomid, okay, for about 5 days, and maximum of 150 units of gonadotropin. So note that I'm saying less amount of medications than I told you in the 25-year-old, right? Because a 25-year-old I know can give me those eggs, so might as well take advantage of it. And believe it or not, a lot of women do really well. And later on, they're like, yeah, Dr. A, you were right. I really doubted that we were not going to get as many eggs. And in fact, I've had some patients with those characteristics who've come in and have done a full stimulation cycle, maybe elsewhere. And we end up getting less eggs with more. So it's always I always say, hey, look, less is more. We always get sometimes more eggs. And even if we don't get more eggs, for sure, we get better quality eggs doing it this way.
Right. So you can still achieve and get a patient's maximum number of eggs that they have to give you using less drugs.
Absolutely.
Yeah. And I think we're just conditioned to think that you take more drugs, you take more meds, you're going to have a higher egg count, but it just doesn't work like that.
No.
So knowing what your IVF expectations are from the start is really important. It sounds like you do an awesome job doing that for patients. So what would your advice be for this 37-year-old AMH of 0.6? I know I'm not telling you a lot. How would you counsel her about her chances of success and what she should expect from her first cycle?
So again, it's about managing expectations. So I would first of all tell her, look, like you're probably going to get about 6 to 8 eggs on average, also depending on what her follicle count is, of course, which we don't know, which can change month to month. So this is our expectations. Sometimes we get less and sometimes we get more, and that we get pleasantly surprised. But the key thing I tell them is, look, the ultimately, your success rates are determined by your age, right? Even if you look at SART data or any other data, it's determined by age. But because you're probably going to get about half the number of eggs that perhaps your peers are going to get in the same age group who have good ovarian reserve, it could also be that you may need to do this more than one time to find that 1 or 2 or 3 good embryos that you're looking for, depending on how big of a family you want. So I kind of manage their expectations in a way as, look, your age is still the number one predictor, but at the same time, because we're dealing with low numbers, you may need to do this more than one time, which is another thing that milder, gentler stimulation helps with, because it's also a lot more cost effective for patients.
Right. No, I agree. So you definitely help your patients keep an open mind.
Mm-hmm.
Having patience throughout this process is very hard because probably the number one Googled thing right now is how to get pregnant fast. And you and I both know that our patients definitely want a solution, but for us, we want to protect our patients and secure future options for them and make sure they have all this information up front. So I'm glad you talked to your patients about that. So now I want to challenge you. I'm kidding, of course. So let's go to this 25-year-old. You just froze her eggs, but a lot of the eggs didn't look so good. So there were physical characteristics that the embryologist described to you, and they called you and said, Dr. A, I just have to tell you, these eggs, they're misshapen, they don't look so good. I just wanted you to know. How would you counsel that patient?
You're right. That is a challenging question. And the reason it's challenging is because most of us don't know. As we know in reproductive endocrinology, this is what I tell women on a daily basis. We can't grade your eggs, right? So I even joke with embryologists. I'm like, really? For every time you were wrong on this egg quality, if I had $1 every time, we would be just doing this all pro bono, right? But the reality is, of course, that once that question is raised, then you're concerned, right? I would tell the patients, look, you're 25, still your number one determining factor is that you're 25. So even if the eggs don't look as pretty as they're supposed to look, doesn't necessarily mean they couldn't result in pretty embryos. Or even if they don't result in pretty embryos, they can still definitely result in pretty babies. Right. But at the same time, I would also counsel her that the only true way of knowing how good the quality of these eggs are is by creating embryos. So if she's truly worried and she truly wants to kind of see how good these embryos are, one of the best tests is to create embryos and see how good of embryos we make. And another advice I usually would give her, and really also all the women who are freezing eggs, is that you don't want to wait to use these eggs 20 years later, right? Because if you come back and use these eggs 20 years later, you're now 45. And if these eggs aren't good, now we're out of that timeline. So try to use them earlier. That doesn't mean you have to get pregnant earlier when you're not ready, because egg freezing is about choice. It's giving women the reproductive choice to do what they need to do and to get pregnant when they want to get pregnant. But at the same time, you don't want them to wait too long to at least thaw and test their eggs to see how good they are.
That's exactly what I tell people as well. It's like we're saying the same thing. I tell people, thaw your eggs when you still have eggs left. So you still have options to make more and create embryos at that age. I think so. So I want to now go through some scenarios for the 37-year-old patient that we talked about with an AMH of 0.6. Let's say you went through the cycle and there were no blasts. So for those of you who are listening and don't know what a blastocyst is, it's an embryo that has hundreds of cells. by definition, and it's an embryo that's usually formed 5 or 6 days after the eggs are fertilized. So what would you do at that point if there were no blasts? You had fertilized eggs, but they didn't make it past day 3.
So unfortunately, that happens sometimes, and it's just so heartbreaking for women, right? Because a lot of times I say, we are not going to know how good your eggs are, how good your egg quality is until we go through IVF. So IVF is a treatment, of course, but a lot of times it becomes a diagnostic process. And for women who end up with no embryos, it's a diagnostic process that at least in that cycle, there were no good eggs. Okay, assuming it's all eggs, right? So the first thing I do is I look back and I look at the grading of the embryos. Okay, because you can get a lot of clues from the grading of the embryos. What happens on day 1? We assess our embryos on day 3. Day 3 embryos are called cleavage stage, and they usually have about 6 to 10 cells on average. Okay, and we know that the first 3 days when the embryo is developing, it primarily depends on the egg, on the mom. Okay, but after the 3rd day, the paternal genome kicks in, which means the dad's contribution comes in. So a lot of times, if that same patient, I saw that she had beautiful day 3 embryos, and then all of a sudden none of them made it to blastocyst, then I start thinking this could also be sperm. Let's not blame it all on the egg, right? So then if I haven't already done additional sperm testing, I would definitely recommend additional sperm testing. One of them being a DNA fragmentation index to just make sure that there's no issue with the sperm and sperm's contribution to embryo development, okay? And I would change things if that does come back abnormal, okay? And luckily there's things one can do to bypass that. And if it's not, if the sperm is okay from the test, and then we would just talk about modifying the protocol a little bit and just doing it again. Because the key thing I tell women, especially women in their 30s, is that I refuse to believe that there's going to be no good egg left in your ovary. So as long as we're persistent, as long as we, make changes, as long as we learn from the past cycles, because I believe that no cycle goes wasted. Even if it doesn't work, we got to learn from it. Then we should be able to modify it. So for that patient, I would make modifications. I would change, the protocol. I would sometimes add growth hormone to improve quality of the embryos. And sometimes we start talking about potentially freezing embryos on day 3, especially if they stopped developing in the culture after day 5. Even though, we have a great state-of-the-art lab that's been around for many, many years, I do still tell patients that maybe there's small percentage of women where their embryos just like being in the uterus, because that's where they're supposed to be naturally. So sometimes we go back to the very, very basics of probably, Amy, what you and I were taught in residency.
Yeah, very true.
5 years ago. We're not old.
So basically you don't give up, because the one thing I didn't hear you say is consider an egg donor.
No.
And so, yeah. And so it's nice that you're going to talk through things with patients. And that's what I'm hoping people will get from listening to us talking right now, is that you and I are doctors in different cities, and we generally have the same positive outlook. So if you're listening to this show and you've had challenges, just know that there are other doctors, other approaches out there. Not that your doctor isn't doing a great job, it's just sometimes getting another opinion, another perspective is really helpful. So I want to give you another scenario and hear how you would approach it, because what you're sharing with us has been extremely informative. So let's say that same patient has blastocysts and they're beautiful. Mm-hmm. But we did genetic testing and we looked at the chromosomes, but none of the chromosomes were normal. What would you do?
So, very similar, but first of all, the first thing, so all of the above still applies, kind of looking at sperm and egg and protocol and things like that. But another key thing that I look at when the embryos are abnormal, and a lot of times I get people coming in for second opinions. My embryos are abnormal. Well, can I see what the actual abnormality is? Because it really, maybe it's my PhD background, but I'm really kind of interested to see, first of all, what chromosomal abnormalities there are and how many chromosomal abnormalities there are, because older women get reproductively, unfortunately, we start seeing more and more different abnormalities in that one beautiful looking embryo. So sometimes I would look through, depending on what the abnormalities are. Occasionally, if there are mosaics, Okay, mosaic means it's a mix of normal cells and abnormal cells. I know we're not talking about that right now, so I don't want to go into too much detail on that. So then we would start talking about the option of potentially maybe using those abnormal embryos as last resort. Okay, my advice, especially after a first cycle, would not be to use those embryos regardless, but I always still discuss the specifics just to make sure that we've addressed it all. And then if it's just chromosomal, so let's say that patient got 3 embryos and all of those 3 blastocysts are abnormal, then we just talk about that sometimes, unfortunately, it's a numbers game. Okay. And when it becomes a number, a 37-year-old on average, I would expect maybe 1 out of 3 embryo to be chromosomally normal. So I would tell that patient, look, you had 3. I was hoping that at least 1 was going to be good, but unfortunately none are good. And again, doesn't mean that none are good in general. It just means this month we weren't able to find normal embryos for you. So a lot of times balancing out happens. We make changes, we come through, make 3 more embryos, and now 2 are good. Mm-hmm. So then now they're overall 4 out of 6. So which is pretty, 2 out of 6, which is great, but sometimes it just kind of changes that way. So we have to always remember that an N of 3 or N of 2 or N of 6 is not really a big number when it comes to embryos. So we have to, but it's a decision with the patient. It just depends on how persistent they want to be and how far they're willing to go.
Yeah. And then same idea, you have blastocysts, but now they're normal, but the quality is really low. So, when we grade embryos, let's just make it simple for our audience. Let's just say good, fair, and poor quality. Let's say you have the 2 embryos that have normal chromosomes, but the quality is poor. How would you counsel your patient?
So I think a lot of that is actually lab dependent. Lab to every reproductive endocrinologist should know their own experience in terms of what their poor quality embryos mean, because as we all know, unfortunately, there's not one universal way of grading embryos when it comes to the embryologists and their method of grading embryos, and it's very subjective. So what I do tell patients, especially if it's poor quality, we do ABC, so poor would mean C. I tell them that the chance of implantation with these embryos are probably lower, okay? But what it doesn't mean is if that you did get pregnant, it does not mean that your child would have abnormalities, or it doesn't mean that this puts you at a higher risk for any other birth defects or something like that. But I do tell them, if I'm going to tell my patients, on average, we see about 65-70% pregnancy rates per chromosomally normal embryo. That number may be cut in half with this embryo. And depending, again, on how big of a family the patient wants and how many children she wants, then we will talk about consider transferring or perhaps creating more embryos.
Yeah, it's super important because you and I have both done the second, third opinion consults for people, and they don't even know that there's such a thing as an embryology report with the quality information. So
Right.
If you're listening to us talking right now, know that quality does matter, and it's important to ask these questions, do a post-IVF consult with your IVF doctor, and go through the things that we normally talk to patients about. So it's important to know that that stuff is important as far as guiding you to give you a roadmap for success. So I want to transition to transfer preparation right now. So how do you get the uterus ready for transfer, and hear about your special sauce and which protocols do you think help your patients prep for transfer the best, and why?
So transfer is what I call the second phase. I always tell patients it's 2 parts to this whole thing. There's many parts, but when it comes to IVF, I usually say, first, let's concentrate on embryos. Once we have the embryos, let's concentrate on getting you ready for transfer. So before transfer, obviously, first of all, we want to make sure that their uterus is okay, meaning there is no polyps or scar tissue or subtle things that would be sometimes missed on a regular ultrasound. So I usually either do a 3D saline sonogram, which is a water test to just make sure that the walls of the uterus are okay, or depending on my level of suspicion for some pathology, I also do diagnostic hysteroscopies, which is put a little camera into the uterus in an office setting, no anesthesia, some like local, women do wonderfully, and just make sure that the uterus is okay. Once I know the uterus is okay and the woman is ready, they're also, this is also a good time to, work on their acupuncture and yoga and their diet and nutrition, because now we're working on getting pregnant, right? And then the actual medical protocol is usually I usually start with medicated cycle. So we go on estrogen for about 2 weeks, okay, which is what basically kind of mimicking our natural cycle. And then if the once the lining is ready, then we start progesterone. And ordinarily we would put the embryo, if it's a blastocyst, I put the embryo in on the 6th day of the progesterone. But a lot of times what I almost always discuss with every patient is the endometrial function test or the endometrial receptivity assay to make sure that the window of implantation, we're getting the window of implantation right? So endometrial receptivity assay is basically doing what I just described, but instead of doing a transfer, we actually take a little sample from the uterine lining, and based on the genetic expression pattern, we determine whether that's the actual correct protocol, correct timing, correct window for that patient, or maybe that patient needs more or less progesterone. So that, I tell them, would potentially optimize, hopefully, our chances of success.
Awesome. So again, I feel like you can host my show. I swear, I mean, your approach is very similar to mine. So it's really cool to see, how you're answering these questions for me. So I want to run some more scenarios by you. Is that okay?
I love scenarios.
Okay, so let's go back. Again, it's a 25-year-old again. So now she's 45 and she met Brad Pitt and he wants more kids. He's 76 now, right? How do you prepare her for that? What do you do to give someone their best chance of pregnancy with their frozen eggs? And the trick here is, the challenging part is especially when the partner is in their 70s.
Right. So that was going to be my number one thing I was going to say. We got to make sure Brad Pitt is, 76-year-old Brad Pitt is still worth thawing those eggs, because I don't think, eggs is key, right? Because we just talked about, we don't want to wait until 45 to use those 25-year-old eggs, but seems like, unfortunately, this patient has waited because she was waiting for Brad Pitt. So
can you blame her though, Gayane? Can you blame her?
I would do the same. So I would just make sure that his sperm is okay first. Right. So, regular semen analysis, but also definitely, especially when I have couples coming in with older male partner, I definitely from the beginning would use the DNA fragmentation index to make sure that the DNA status of the sperm is okay. Right. And again, I don't want viewers to go away thinking DNA fragmentation test is going to tell us everything we need to know about the sperm quality. If it's okay, then the sperm is going to perform perfectly, because it doesn't necessarily mean that, but it's another measure data point available to us. So that would be one thing. And the second thing, I may actually, depending on how many eggs she froze at age 25, if she has a lot of eggs frozen, especially given that he's 76 and we don't know exactly what his true sperm quality is, may not be a bad idea. I would tell her to perhaps thaw half of the eggs, right? Because a lot of times it's a cost issue, but if it's Brad Pitt, he can afford it.
I think that's great advice, honestly. That's exactly what I would say too.
So just to make sure that we're doing okay, you can always go back. I always tell patients, look, we can always go back and thaw more eggs, but we can't unthaw. We can untangle them, unfertilize them, and put them back in. So we can always go forward, but we can't go backwards. So that would be one thing that I would advise her. And then for her, of course, first of all, because she's 45, I would make sure she's health-wise, not that 45 is old, but I would make sure that health-wise she's ready for pregnancy. So make sure she's had her mammogram, make sure she's had her pap smear, and all of those things ready. Her thyroid's good, no high blood pressure, because of course women in their 40s unfortunately are at higher risk for complications of pregnancy. And then I would do kind of like the same thing we talked about earlier on, uterine evaluation with the camera test most likely, and then I would definitely do the endometrial receptivity test for her and the ERA to make sure we're getting the window of implantation correct. And if I have any other suspicion for, let's say, endometriosis or adenomyosis or things like that, then there is a second test that I would generally add to make sure that there's no increased markers, which is the receptiva, to make sure that there's no increased markers of inflammation and endometriosis.
Great. So you have a very thorough approach. When you've frozen your eggs and you're ready to thaw them, you don't just hope and see that everything's going to be okay. You have to go through all these steps because you don't want to have regret, because your eggs are such a precious commodity. You can't get them back, especially when you're 45. Yeah, super important. Okay, so now your 37-year-old patient, she's ready to transfer. My question for you is, would your preparation be different if you knew she had 4 embryos versus 2 embryos? And I kind of know the answer to this question already, knowing that she wants 2 kids. I know what you're going to say, but I'll let you say it.
You can read my mind.
I know.
So, sometimes it ends. So we talked about so basic testing is the same. No one skips uterus evaluation. No one skips polyp test and whatnot, and all the basic thyroid well-being and all that stuff. But one thing that sometimes I would not do is the ERA, the endometrial receptivity assay, right? So I tell everyone about it. So we make a decision together. It's an educated decision, but I also tell them, look, the reality is this test is actually usually generally used after 1 failed cycle, right? I'm telling you about it because we want to be proactive. We want to just make sure we're doing all that we can. But most women are most likely not going to need it. Right? So that would be one difference. If someone has a couple embryos, not that every embryo isn't precious, but when you have less, they tend to be more precious. So, but if someone has a good number of embryos, then I would be willing to perhaps skip the ERA. But other than that, everything else is the same.
Okay. So let's say she did the ERA, she transferred 1 embryo, and it didn't work. What would you do then?
Mm-hmm. Right? If those are always the challenging questions, because the patients say, well, we did everything. How come I'm still not pregnant? Can I even get pregnant? And these are such difficult consultations to do, because the reality is it's most likely embryo related, right? Because no embryo is perfect. So even a chromosomally normal embryo could have other abnormalities that would result in it not implanting, okay? Or maybe that embryo didn't like being tested. So perhaps even because of the test, that embryo had a hard time implanting, although in the right hands, most embryos do beautifully and they're not harmed. I don't want people to think they're harmed by PGS, but I do think that a small percentage can be, and we can't really predict that ahead of time. If I've done everything else, I've done the receptivity test. If I have concerns about endometriosis, I may have already done the Receptiva test. If not, I would do the Receptiva test to make sure we're not missing something subtle that is perhaps not allowing for the embryo to implant. Then we start kind of going down the route of, are there any other factors that are perhaps impacting this embryo's ability to implant? Well, namely, of course, a lot of people already bring it up from their Google search, immune factors, right? It's a big keyword, natural killer cells. Can we check my natural killer cells? The reality is what we check in the blood doesn't really reflect what's in the uterus. And as we all know, there's not a lot of actual scientific data on this immune protocols. But if I do have any concerns, then we start talking about potentially, approaching it from that angle. And I do have a special immune sauce that I use with some patients if needed.
Can you tell us what that immune sauce is? Is that privileged?
Sure.
What is it?
I use intralipids. Okay, so the patients would usually do intralipid infusion a week before transfer, and hopefully if they are pregnant, then they would do it again, which is about 3 weeks later. And intralipids, the thought is that it's going to hopefully kind of get rid of, chelate some of the immune markers in the blood that could potentially impact implantation. Okay, we go on baby aspirin and blood thinners, Lovenox, and prednisone.
Great.
There's very many variations of different protocols out there. So that's
right.
my
Yeah, I mean, we all have our own special sauce, and it sounds like we have very similar recipes. Well, Gayane, it's been so great talking to you and having you on today's show. Thank you. And I would love for you to share with our audience again, where can they find you?
So I'm with Reproductive Partners in Redondo Beach. We actually have 3 locations, and one in Beverly Hills and one in Long Beach in Orange County. But I'm in Redondo Beach, and I pretty much take care of a lot of the patients in the South Bay. So if you need my expertise, feel free to find me.
Awesome. Well,
Thank you for having me.
Of course. I hope to have you back on the show. Will you come back on again soon?
Absolutely.
And I'll challenge you again with more scenarios. Obviously, you had no problem with the challenges, obviously.
I love a challenge.
Yeah. Good. Well, thank you again.
Of course.
Well, everyone, thank you for watching tonight's show. Please tune in next time. Be sure to hit subscribe on YouTube. And do take my Tushy class or my IVF class if you haven't already. You can go to eggwhispererschool.com. Bye, guys. Have a great night.
Bye.
Bye, Gayane.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer. Fertility expert Dr. Amy Ambartstumyan.
And you have yet another success story.
Just launched by an East Bay fertility doctor.